Thank you so much for having me, invite me for this talk. The last speaker was incredible. That was a very nice presentation. Thank you for that very kind introduction. I have no financial disclosures. And the purpose of my talk today is sort of to bring light some clinical applications of functional MRI that we do in the hospital on a regular basis. I'm talking to a group of experts, but just to reiterate, functional MRI is a non-invasive imaging technique, and we take advantage of brain activity by detecting subtle changes in blood flow to areas of neural activity. And the main thing that we're capitalizing on is blood oxygen level dependent signal, which increases in those areas. And this allows us to visualize brain activity in real time, either during task-based functions or at rest. And just to sort of bring about or highlight the obvious, we're sort of highlighting differences between structural MRI, where we take images and we just sort of look at the anatomy of the brain, or depict intracranial pathology, versus functional MRI, where we're actually seeing the brain in action. So some of the main clinical applications of functional MRI that we use are, for the most part, pre-surgical planning, either for neuro-oncological cases or epilepsy surgery. As you're very well aware of, there is applications for functional MRI with neurological disorders and mental health, but these really are predominantly in the research domain. And so how does functional MRI works? It relies, as I mentioned before, on capitalizing on the BOLD, or blood oxygen level dependent signal, which reflects microscopic changes in blood oxygenation when neurons become active. So our mind is or our brain, I should say, is exposed to a stimulus, and there's certain neurons that become more active, and then in this local environment to those areas, to those neurons that are being activated. As a result, we see elevated cerebral blood volume, cerebral blood fusion. But because of that microscopic change in blood flow to those neurons that are being activated, we, as a result, see subtle changes in the local microscopic magnetic field. That's what we mean by blood oxygen level dependent, or the BOLD signal. So let's go one step further and sort of talk about the BOLD phenomenon. As I mentioned, their blood flow increases to provide oxygen and glucose to increase energy production in those areas that are becoming active. So oxygenated blood, or oxyhemoglobin, is isomagnetic. Deoxygenated blood is slightly paramagnetic, and as a result, distorts the local magnetic field. So these subtle changes in the microscopic magnetic environment allows us to sort of acquire functional MRI brain signal. In areas where there's not a lot of neuronal activity and there's more deoxygenated blood, that sort of distorts the magnetic field, and you get T2 star relaxation or static dephasing. Don't really have time to go into the hardware that we use, but you can imagine that these are very subtle changes, and so we have to acquire images very quickly. And so most of the sequences that we acquire are echoplanar imaging, and these are incredibly fast. So when a patient comes to our hospital, to the department, first thing we want to do is we want to coach them. We want to tell them what we're doing. It's important that you have a patient that is able to sort of follow the commands and follow the procedures, and we can have them perform a whole variety of tasks depending on what we're interested in highlighting or what we're interested in depicting on the functional MRI. We have a unit in our scanner that can provide the tasks in about 30 different languages, so hopefully usually there is not a language barrier. And then the patient goes on the table, the fMRI and the structural imaging is acquired, and the data is sent to a third software that we use for post-process and evaluating the data, and then coming up with our assessment and report. Clinically speaking, most fMRI procedures use what's called a block design paradigm. So the patient's on the table, the scanner, there's a lack of stimulus. Then a stimulus is given to the patient. They perform the stimulus, and at the same time, the bold response you can see is sort of being activated. And we go through multiple iterations between the non-stimulus component and then stimulus aspect. And then on the back end, all the images are post-processed, and then we can get sort of a activation map where the clinician and the neuroradiologist can scroll through these images looking for areas of activation based on that particular task. So I'm going to go through each of the types of functional tasks that we perform clinically and what we're interested in. So the main one that we do most often is motor mapping. The idea is to identify the precentral gyrus and its vicinity to a primary lesion. Typical tasks that we perform are finger tapping, foot movement, tongue movement. Just want to remind you of the homunculus and how there's a cortical representation of different motor movements along the precentral gyrus, or for somatosensory activity on the postcentral gyrus. And typically with a normal structural MRI, we can easily identify the central sulcus. With my residents, I sort of go through 8 to 10 different landmarks, how they can identify the central sulcus. But imagine if you have this huge mass and there's distortion of surrounding brain parenchyma, this can become a little bit more challenging. So on finger tapping, here's an example of finger tapping, and we can easily identify the precentral gyrus. Typically, foci of activation in the premotor cortex sort of lies along the posterior aspect of the cortex. So whereas these foci are kind of like actually residing or sort of overlaid on the central sulcus, it's the gyrus that's a little bit anterior to it that is the premotor cortex. This is an example of where the clinicians want us to specifically have the patients do finger tapping with the left and right hand separately, and foot tapping with the left and right hand of a foot separately. These were not performed at the same time. We're just able to sort of overlay these color maps on the same anatomical image. But when the patient was able to finger tap with the right hand or move their foot with the right foot, we can see sort of the areas of activation. Again, as we would expect for areas along the homunculus. In these two cases, you can see areas of activation at the midline, at the expected location of the supplemental motor area. So in this patient with seizure activity in a large area of gliotic brain tissue, we're able to sort of highlight areas of finger tapping and foot tapping. And going back to that original example I showed you before, there's a large extraaxial mass. It's most likely a meningioma, but it's hard to say if the precentral gyrus has been pushed forward or pushed back. We can say confidently to our neurosurgeons that it's pushed backwards, and this may actually help them sort of pre-pan if they want to take an anterior or posterior approach. Next, another common task that we'll perform is language mapping. The main objective is to determine which hemisphere is dominant, whether it's the left or right, and we'll try to identify Broca's or Wernicke's area. The two main tasks we do are word generation. We ask the patient to say as many words as they can that start with a specific letter. This typically helps us highlight the Broca's area. And then verb generation is the other common language test that we ask them to perform, where patients are presented with nouns and they generate appropriate verbs to describe that noun. Here's an example of a patient performing the verb and generation task. We sort of overlaid those two tasks on the same anatomical structural images. You can see that this patient has left-sided language dominance. Same patient, different patient, verb and word generation. Again, there's left-sided language dominance. A third patient, and guess what? There's left-sided language dominance. This is not a coincidence, as you are probably fully aware. About 85 to 90% of the general population has left-sided language dominance. For whatever reason, in my own personal experience, we're able to sort of highlight or demonstrate more robust signal in Broca's area compared to Wernicke's. We usually have a lesser degree of bold activation in the expected regions of Wernicke's area. Here's a nice example of a patient presenting with an intracranial lesion in the periatrial white matter region in the left temporal occipital region. It's in close proximity to where we would expect Wernicke's area to be. And after performing verb and word generation tasks, say that 10 times quickly, we can see that there's left language dominance, but more importantly, there's foci bold activation in close proximity to the primary lesion, and that's helpful for the neurosurgeon to know. Not only did he need to be aware of that, but they may decide whether or not they want to do a closed, an asleep craniotomy under full general anesthesia, or in rare occurrences, they may do an awake craniotomy. When the patient's awake, they can perform the surgery and they can undergo neuropsych testing at the time of surgery to preserve those eloquent regions. And lastly, another common, or not as common, but we may sometimes perform visual cortex mapping, where we will try to identify the primary visual cortex. We can perform object recognition. The patient's shown a series of objects or images and has to name them. Or with motion perception, we can have the patient track an image across the screen. I couldn't find one of my own examples because we don't perform this live, so pardon me, I apologize. But I borrowed an example from the literature. Here's an arterial venous malformation in the left temporal occipital region. And during a visual task, we can see foci bold activation in the bilateral occipital lobes. So let's look at some interesting examples. Here is a patient presenting with a primary lesion in the left temporal occipital region. This is a side profile or a sagittal image. This is the front, back, top, bottom. And we can see that this patient is left-sided dominant. But I wanted to bring up this sagittal profile to you, that you can have sort of variability in where Wernicke's area can be located. Typically, most diagrams in the anatomy books will tell you that's around here, but we can see all sorts of variation. In this case, it almost seems to be that's in the posterior temporal lobe, and once again, it's in close proximity. Foci bold activation pertaining to language are in close proximity to this primary lesion. Here is another example of a primary lesion, intracranial lesion in the left centrum sinovial valley. This is a 3D rendered image with DTI tracks. For the sake of this talk, unfortunately couldn't talk about diffusion tensor imaging, but I just wanted to include these cortical spinal tracks. And again, foci bold activation during the finger tapping task. And we can see that during these, if you scroll through these 3D rendered images, the primary lesion is posterior to foci of bold activation. So it's more in the parietal lobe rather than the frontal. Lastly, here is an example of an arterial venous malformation, a rather large one. On the finger tapping task, we can see foci bold activation in the expected region in the premotor cortex. As we go lower down, we also had this patient perform foot tapping because we expected anatomically that may be disturbed or in close proximity to the large AVM. And this highlights an interesting conundrum or interesting challenge we sometimes have. We can see the foot foci bold activation related to foot tapping on the left, but we do not see it on the right. And that highlights a not so rare phenomenon or challenge we have to deal with, which is called neurovascular decoupling. I mentioned before how fMRI is really relying on bold signal. And so entities or diseases like an AVM, a high-grade glioma, they can cause microscopic shunting of blood flow. And as a result, we may have a false negative absence of bold signal. So this is a nice example of most likely neurovascular decoupling, and as a result, we cannot highlight foci bold activation related to foot tapping. So in conclusion, fMRI is an incredibly useful, reliant modality that we can perform non-invasive imaging to localize areas of motor, language, and vision for patients with primary lesions or undergoing epilepsy surgery. As I mentioned, it's non-invasive, and I like to sort of share or remind people that once upon a time, before functional MRI, when we wanted to sort of evaluate language dominance, we'd have to perform WADA testing or balloon occlusion tests, where you put a catheter up in the internal carotid and you might inflate a balloon, or you administer pharmacologic agents to cause a temporary paralysis. So obviously, functional MRI is a little bit less invasive than that. And there's exciting future directions. Again, couldn't talk about it for the sake of this presentation, but mainly resting state fMRI, looking at what brain activity looks like if patients are just at rest, and what are sort of the neuronal or functional interlay that exists between different areas of the brain during functional state fMRI. And that really has given risen to this new exciting field of kinetomics. Thank you so much, and I hope that was helpful. Yes, sir.
Elementary question. Is it known which are the dominant neuronal functions that are responsible for the signal? What I mean, for example, is it known whether action potentials or synaptic potentials are the dominant source of the signal, or principal neurons or interneurons?
That's
Can you
that's a
break?
great question. Unfortunately, I don't know. Probably that would have to be answered by someone who's a lot smarter than me on the PhD side, microscopically speaking. All I know is that from the, like I mentioned, from the most of the signals acquired from those subtle changes in the magnetic fields related to increased blood flow and delivery of oxygenated
Presumably
blood.
that the oxygen is related to the metabolism of glucose to
Mhm.
produce ATP to supply the energy for some neuronal function. But there's a bunch of steps in there, and I was just
Of
wondering
course, yeah.
how precise that was known.